Foundations of Maternal, Newborn, and Women's Health Nursing by Murray McKinney, Hollobin Jones, 7th edition. Chapter 4, Hereditary and Environmental Influences on Childbearing. Hereditary and environmental forces shape a person's development from before conception until death. As people learn more about genes and their influences on the body's function, they are discovering genes have more influence on health, disease, and medication effectiveness than was previously thought. The nurse needs a basic knowledge of these forces to better understand disorders evident at birth, congenital, and those that develop later in life. This chapter reviews the basics of hereditary influences on development and the impact of environmental factors in causing birth defects. The nursing role in relation to genetic knowledge is also discussed. Hereditary influences. Hereditary or genetic influences pertain to developmental results that direct cellular functions provided by genes that constitute the 46 chromosomes in every somatic cell. Disorders can result if too much or too little genetic material is present in the cells, and if one or more genes are abnormal and provide incorrect directions. Structure of genes and chromosomes. A review of the structure of genes and chromosomes aids in understanding the reasons for the occurrence of disorders. Chromosomes are composed of genes that in turn are composed of deoxyribonucleic acid, DNA, figure 4.1. Deoxyribonucleic acid. DNA is the building block of genes and chromosomes. Its three units are 1, a sugar, deoxyribose, 2, a phosphate group, and 3, one of 4 nitrogen bases, adenine, thymine, guanine, and cytosine. DNA resembles a spiral ladder, with a sugar and a phosphate group forming each side of the ladder and a pair of nitrogen bases forming each rung of the ladder. The 4 bases of the DNA molecule pair in a fixed way, allowing the DNA to be accurately duplicated during each cell division. Adenine pairs with thymine. Guanine pairs with cytosine. The DNA also directs the manufacture of proteins needed for cell function. The sequence of bases within the DNA determines which amino acids will be assembled to form a protein, and the order in which they will be assembled for cell processes. Some proteins form the structure of body cells, whereas others are enzymes that control metabolic processes within the cell. If the sequence of nitrogen bases in the DNA is incorrect, or some bases are missing or added in critical places, a defect in body structure or function may result. Bases are arranged in groups of 3 called codons for translation into a specific amino acid in the cell. For example, a triplet base codon may consist of the bases GCC, guanine, cytosine, cytosine, which tells the cell to produce the amino acid alanine. Other codons, known as stop codons, signal the end of a gene sequence. Genes. A gene is a segment of DNA that directs the production of a specific product needed for body structure or function. Humans have 23,000 genes arranged on their chromosomes. Only a portion of the long strand of DNA that forms a chromosome makes a single gene. Some genes are active only during prenatal life, and others become functional at various times after birth. Gene regulation is the process of turning genes on and off. During early development, cells begin to take on specific functions. Gene regulation ensures the appropriate genes are expressed at the proper times. Gene regulation also helps an organism respond to its environment. Gene regulation is accomplished by a variety of mechanisms, including chemical modification of genes and the use of regulatory proteins to turn genes on and off. Genes that code for the same trait often have 2 or more alternative forms, or alleles. Familiar examples of alleles are the ABO blood types. Normal alleles provide genetic variation and sometimes a biologic advantage. If an allele occurs at least 1% of the time in the population, it is called a polymorphism. Some changed gene forms or mutations may be harmless, but many are harmful, such as those that cause the production of abnormal hemoglobin in sickle cell disease. Mutations may cause harm by the following actions: substituting incorrect bases for the normal bases, interrupting the normal gene sequence or stopping it prematurely, duplicating some bases or entire gene sequences, adding or subtracting some bases within those making up a gene sequence of bases, which will alter the amino acids it causes to be assembled. A mutation may occur in gametes, reproductive or germ cells, or somatic cells, other body cells. If the mutation occurs in a gamete, the mutation can be transmitted from one generation to the next. Mutations occurring in somatic cells are often associated with malignant change, but they are not transmitted from generation to generation. Genes are too small to be seen under a microscope, but they can be studied in the following ways. By measuring the products they direct cells to produce, such as an enzyme or other substance, by directly studying the gene's DNA, by analyzing the gene's close association, linkage, with another gene that can be studied in one of the previous two ways. The tissue used for study of a gene depends on where the gene product is present in the body and the available technology. These tissues may include blood, skin cells, hair follicles, and fetal cells from the amniotic fluid or chorionic villi. Genes that can be identified by direct analysis of DNA can be studied in any cells containing a nucleus, even if the gene product is not present in that tissue. Although not always used, DNA analysis of the blastomere, 8-cell stage of prenatal development, can be used to select embryos to be implanted in the uterus after in vitro fertilization. This prevents implantation of embryos with a specific gene defect or common chromosome defects. The National Human Genome Research Institute is part of the National Institutes of Health. The Human Genome Project is an international effort started in 1990 to identify all genes contained in the human body. Benefits of greater knowledge about specific human genes includes the following: performing genetic testing to determine the risk for a disorder or the actual or probable presence of the disorder, basing reproductive decisions on more accurate and specific information than has previously been available, identifying genetic susceptibility to a disorder so interventions to reduce risk can be instituted, using gene therapy to modify a defective gene, modifying therapy such as medication based on individuals' genetic code or the genetic makeup of tumor cells, individualizing treatment or medications for a specific person. The explosion of knowledge about the genetic basis for many diseases raises many legal and ethical issues for which we do not yet have answers. Box 4.1. As our knowledge base grows, new issues are likely to emerge. Genetic information has implications for others in the person's family, raising privacy issues. Knowledge about a genetic order often precedes knowledge about treatment of the disorder. Identification of genetic problems could lead to poor self-esteem, guilt, and excessive caution, or, conversely, a reckless lifestyle. Pre-symptomatic identification of genetically influenced illness would be a source of long-term anxiety. Genetic knowledge could affect one's choice of a partner. Concern about employment or insurance coverage related to genetic tests was addressed in the United States in 2008 with the enactment of the Genetic Information Non-Discrimination Act, GINA. Insurance companies and employers are prohibited from discriminating on the basis of information from genetic tests. Insurance companies are prohibited from discriminating in ways such as canceling, denying, refusing to renew, or changing the terms or premiums based solely on a genetic predisposition toward a specific disease. Employers are prohibited from using genetic information when making employment decisions. A genetic test cannot be demanded by an employer or insurance company. The GINA document further clarified genetic information as part of an individual's health information, and this rule was implemented in 2013. Chromosomes. Genes are organized in 46 paired chromosomes in the nucleus of somatic cells. A gene can be likened to a single bead. A chromosome is like a string of beads. Each chromosome is composed of varying numbers of genes. A total of 22 chromosome pairs are autosomes, non-sex chromosomes. And the 23rd pair is composed of the sex chromosomes, XX female or XY male. Added, missing, and structurally abnormal chromosomes are usually harmful. Homologous chromosomes carry matching genetic information. That is, they have the same genes in the same sequence. Mature gametes have half the chromosomes, 23, of other body cells. One chromosome from each pair is distributed randomly in the gametes, allowing variation of genetic traits among people. When the ovum and sperm unite at conception, the total is restored to 46 paired chromosomes. Cells for full chromosome analysis must have a nucleus and be living. Chromosomes can be studied by using any of the several types of cells: white blood cells, skin fibroblasts, bone marrow cells, and fetal cells from the chorionic villi of the placenta or suspended in amniotic fluid. Unlike genes, chromosomes can be seen under the microscope, but only during cell division for a full chromosome analysis. Specimens should be obtained and preserved carefully to provide enough living cells for chromosomal analysis. Temperature extremes, blood clotting, and the addition of improper preservatives can kill the cells and render them useless for analysis. Chromosomes look jumbled before they are arranged into a karyotype, figure 4.2. Systematic study is possible using imaging of prepared chromosomes and then arranging them into a karyotype, figure 4.3. In a karyotype, autosomal pairs are arranged from largest to smallest. Letters describe groups of similar size and appearance. Sex chromosomes may be arranged in a separate group. A person's karyotype is abbreviated by a combination of numbers and letters. The number describes the total number of chromosomes, followed by either an XX to indicate the sex chromosomes are female, or an XY to indicate they are male. Therefore, the chromosome complement is abbreviated as 46XX for a normal female and as 46XY for a normal male. If the chromosome number or structure is abnormal, as in Down syndrome, Trisomy 21, which has an extra 21 chromosome, an added abbreviation indicates the abnormality, 47, total number of chromosomes, XY, male, plus 21, the number of the extra chromosome. Other abbreviations describe karyotypes with missing or structurally altered chromosomes. Finer chromosome analysis uses fluorescent labeled DNA probes that attach to specific chromosomes. This technique is called fluorescence in situ hybridization, or FISH, and permits testing for added, missing, or rearranged chromosome material that otherwise may not be visible microscopically. FISH analysis can be done rapidly because stimulation of cells to divide is not required, as in other types of chromosome analysis. Another, more specific chromosome analysis is the comparative genomic hybridization used to identify losses or duplications of specific chromosome regions, which often occur in tumor cells. Transmission of traits by single genes. Inherited characteristics are passed from parent to child by the genes in each chromosome. These traits are classified according to whether they are dominant, strong, or recessive, weak, and whether the gene is located on one of the autosome pairs or on the sex chromosomes. Both normal and abnormal hereditary characteristics are transmitted by these mechanisms. Because humans have pairs of matched chromosomes, except for the sex chromosomes in the male, they have one allele for a gene at the same location on each member of the chromosome pair. The paired allele may be identical, homozygous, or different, heterozygous. Some genes, both normal and abnormal, occur more frequently in certain groups than in the population as a whole. For example, the gene that causes Tay-Sachs disease on chromosome 15 is carried by approximately 1 of every 30 U.S. Jews. This rate is also similar in persons of French-Canadian ancestry and members of the Cajun population in Louisiana, and is approximately 100 times its occurrence in the general population. Because the abnormal gene occurs more frequently in these groups, their incidence of Tay-Sachs disease is also higher. Other disorders that are more common in certain ethnic groups are cystic fibrosis, which occurs primarily in whites of Northern European descent, and sickle cell disease, which occurs more frequently in people of African descent. Dominance. Dominance describes the way a person's genotype, genetic composition, is translated into the phenotype, or observable characteristics. In the case of a dominant gene, one copy is enough to cause the trait to be expressed. For example, in the ABO blood system, genes from types A and B are dominant. Therefore, a single copy of either of these genes is enough for it to be expressed in the person's blood type. 2 identical copies of a recessive gene are required for the trait to be expressed. The gene for blood type O is recessive. Laboratory testing identifies a person's blood type as O only if that person receives a gene for blood type O from both parents. If the person receives a gene for type O from one parent and type A from the other parent, blood type A is expressed in laboratory blood typing. On the basis of dominant and recessive forms of a gene, a person with type A blood can have one of the following 2 possible combinations of gene alleles: 2 type A alleles, or 1 type A allele and 1 type O allele. Other alleles are equally dominant. The person who receives a gene from blood type A from one parent and type B from the other will have type AB blood because both alleles are equally dominant and expressed in blood typing. Dominance and recessiveness are relative qualities for many genes. Some people have a single copy of an abnormal recessive gene, carriers, may have a lower than normal level of the gene product, e.g. an enzyme, that can be detected by biochemical methods. These people often do not have overt disease because the normal copy of the gene produces enough of the required product to allow normal or near normal function. Chromosome location. Genes located on autosomes are either autosomal dominant or autosomal recessive, depending on the number of identical copies of the gene needed to produce a trait. However, genes located on the X chromosome are paired only in females because males have one X chromosome and one Y chromosome. A female with an abnormal recessive gene on one of her X chromosomes usually has a normal gene on the other X chromosome that compensates and maintains relatively normal function. However, the male is at a disadvantage if his lone X chromosome has an abnormal gene. The male has no compensating normal gene because his other sex chromosome is a Y. The abnormal gene is expressed in the male because it is unopposed by a normal gene. Patterns of single gene inheritance. 3 major patterns of single gene inheritance are autosomal dominant, autosomal recessive, and X-linked, box 4.2. Few genes are found on the Y chromosome, primarily the one that causes the embryo to differentiate into a male. Because few Y-linked traits have been identified, these will not be discussed. Although the word pedigree is widely used among genetic professionals, the nurse may need to interpret it for the patient. Be cautious when referring to the illustration of a family's genetic history as a pedigree, because some associate the word only with animals. For example, when taking a genetic family history, the nurse might say, "I'm going to use several symbols to depict your family tree and its members." Health histories. This diagram is called a genogram, but it is often called a pedigree. Single gene traits have mathematically predictable and fixed rates of occurrence. For example, if a couple has a child with an autosomal recessive disorder, the risk that future children will have the same disorder is 1 in 4, 25%, at every conception. The risk is the same at every conception, regardless of how many of a couple's children have been affected. Autosomal dominant traits. An autosomal dominant trait is produced by a dominant gene on a non-sex chromosome. The expression of abnormal autosomal dominant genes may result in multiple and seemingly unrelated effects in the person. The gene's effects also may vary substantially in severity, leading a family to believe incorrectly that a trait skips a generation. A careful physical examination may reveal subtle evidence of the trait in each generation. In other cases, some people may carry the dominant gene but have no apparent expression of it in their physical makeup. In some autosomal dominant disorders, such as Huntington's disease, those with the gene will always have the disease if they live to the age at which the disorder becomes apparent. In other disorders, only a portion of those carrying the gene ever exhibit the disease. New mutations account for the introduction of abnormal autosomal dominant traits into a family with no history of the disorder. In this case, parents of the child are not affected because their body cells do not have the altered gene. The person who is affected by an autosomal dominant disorder is usually heterozygous for the gene. That is, the person has a normal gene on one chromosome and an abnormal gene on the other chromosome of the pair. Occasionally, a person receives 2 copies of the same abnormal autosomal dominant gene. Such an individual is usually much more severely affected than someone with only 1 copy. Autosomal recessive traits. An autosomal recessive trait occurs if a person receives 2 copies of a recessive gene carried on an autosome. Everyone is estimated to carry abnormal autosomal recessive genes without manifesting the disorder because everyone has a compensating normal gene. Because of the low probability of 2 unrelated people sharing even one of the same abnormal genes, the incidence of autosomal recessive diseases is relatively low in the general population. Situations that increase the likelihood that 2 parents share the same abnormal autosomal recessive gene are as follows. Consanguinity, blood relationship of the parents. Blood relatives have more genes in common, including abnormal ones. Groups isolated by culture, geography, religion, or other factors. The isolation allows abnormal genes to become concentrated over the years and occur at a greater frequency than in more diverse groups. Many autosomal recessive disorders are severe, and affected persons may not live long enough to reproduce. 2 notable exceptions are phenylketonuria, PKU, and cystic fibrosis. Improved care of people with these disorders has allowed them to live into their reproductive years. If one member of the couple has the autosomal recessive disorder, all their children will be carriers. Their child's risk for having similarly affected children is also higher, depending on the prevalence of the abnormal gene in the general population and the likelihood that their mate is a carrier. X-linked traits. X-linked recessive traits are more common than X-linked dominant traits and are the only X-linked pattern discussed in this chapter. Gender differences in the occurrence of X-linked recessive traits and the relationship of affected males to one another are important factors distinguishing these disorders from autosomal dominant and recessive disorders. In general, males are the only ones to show full effects of an X-linked recessive disorder because their only X chromosome has the abnormal gene on it. One of the two X chromosomes is inactivated randomly in a normal female embryo. The active X chromosome in cells usually provides adequate cell function, although one of the two X chromosomes is inactivated. Bar bodies seen in female cells indicate the inactive X, and they are not seen in normal male tissue samples. Females can show the full disorder in the following two uncommon circumstances. If a female has a single X chromosome, Turner syndrome, or if a female child is born to an affected father and a carrier mother. X-linked recessive disorders can be relatively mild, e.g. color blindness, or they may be severe, e.g. hemophilia. In addition, those having the disorder may be affected with varying degrees of severity. Chromosomal abnormalities. Chromosomal abnormalities can be numerical or structural. They are quite common, greater than 50%, in the embryo or fetus spontaneously aborted, miscarried. Chromosomal abnormalities often cause major defects because they involve deletion or duplication of many genes. The normal number of chromosomes in body cells other than reproductive cells is 46. Referred to as diploid. Numerical abnormalities. Numerical chromosomal abnormalities involve added or missing single chromosomes or multiple sets of chromosomes. Trisomy and monosomy are numerical abnormalities of single chromosomes. The term polyploidy refers to abnormalities involving full sets of chromosomes. Trisomy. A trisomy exists when each body cell contains an extra copy of one chromosome, bringing the total number to 47, figure 4.4. Each chromosome is normal, but too many are present in each somatic cell. The most common trisomy is Down syndrome, or trisomy 21. In which 3 copies of chromosome 21 are in each somatic cell. Trisomies of chromosomes 13 and 18 are less common and have more severe effects. The incidence of bearing children with trisomies increases with maternal age, so most women who are 35 years or older and becoming pregnant are offered prenatal diagnostic screening to determine whether the fetus has Down syndrome or another trisomy. Infants with Down syndrome have characteristic features usually noticed at birth, figure 4.5. Chromosomal analysis is performed during the neonatal period to confirm the diagnosis and determine whether Down syndrome is caused by trisomy 21 or a rarer chromosomal anomaly involving a structural rather than a numerical abnormality of chromosome 21. Children with Down syndrome reach developmental milestones more slowly than unaffected children. Their intellectual development is delayed, although the severity varies, just as intelligence varies in the general population. Early intervention programs and regular medical care help these children reach their full ability and manage the physical problems associated with Down syndrome. Klinefelter syndrome is a trisomy of the sex chromosomes. Males with Klinefelter syndrome, 47XXY, are taller than average, may have a lower intelligence and gynecomastia, larger breasts, and are usually sterile. Testosterone therapy and mastectomy for enlarged breasts may be done. Other sex chromosome trisomies possibly encountered include 47XXX or 47XYY. Monosomy. A monosomy exists when each body cell has a missing chromosome with a total number of 45. The only monosomy compatible with postnatal life is Turner syndrome, or monosomy X, figure 4.6. Over 99% of conceptions with the 45XO karyotype are lost in spontaneous abortion. The person with Turner syndrome has a single X chromosome and is always female. Large cystic masses on either side of the neck, cystic hygromas, may be found on routine ultrasonography and lead to the diagnosis. Live-born infants have excess skin around the neck left from the hygromas and edema most noticeable in the hands and feet during infancy. If Turner syndrome is not identified and treated during infancy or childhood, an affected girl will remain very short and will not have menstrual periods or develop secondary sex characteristics. Children with Turner syndrome usually have normal intelligence, although they may have difficulty with spatial relationships or with solving visual problems such as reading a map. The girl may have a broad shield-like chest with widely spaced nipples. Her kidneys may be joined at their upper poles, horseshoe kidney, and coarctation of the aorta may require corrective surgery. Treatment with estrogen at the age of puberty promotes development of secondary sexual characteristics. Continuing estrogen throughout life reduces development of osteoporosis. Polyploidy. Polyploidy may occur when gametes do not halve, that's H-A-L-V-E, their chromosome number during meiosis and retain both members of each pair, or when two sperm fertilize an ovum simultaneously. The result is an embryo with one or more extra sets of chromosomes. The total number of chromosomes is a multiple of the haploid number of 23, 69 or 92 total chromosomes. Polyploidy usually results in an early spontaneous abortion, but may occasionally be seen in a live-born infant. This abnormality may be found in chorionic villus sampling, see Chapter 9, and may reflect an abnormality of the chorionic villi rather than of the fetus. Structural abnormalities. Chromosomal abnormalities may involve the structure of one or more chromosomes. Part of a chromosome may be missing or added, or DNA within the chromosome may be rearranged. Some of these rearrangements are common, harmless variations. Others are harmful because important genetic material is lost or duplicated in the structural abnormality, or the position of the genes in relation to other genes is altered so that their normal function is not possible. Another structural abnormality occurs when all or part of a chromosome is attached to another, translocation, figure 4.7. Many people with a translocation chromosomal abnormality are clinically normal because the total of their genetic material is normal or balanced. If a parent has a balanced translocation, the offspring, like the parent, may have completely normal chromosomes or a balanced translocation. However, the offspring may receive too much or too little chromosomal material and be spontaneously aborted or have birth defects. Balanced translocations are often discovered when amniocentesis reveals a translocation in the fetus, or during infertility evaluations if a history of recurrent spontaneous abortions is reported. Either balanced or unbalanced chromosomal translocations may occur spontaneously in the offspring of parents who have no translocation. Fragile X syndrome is an X-linked chromosomal abnormality. The syndrome was so named because a site on the X chromosome demonstrates breaks and gaps when the cells are grown in a medium deficient in folic acid. The syndrome is now usually diagnosed by molecular DNA studies. As in other X-linked traits, males are more severely affected than females, who have a compensating X chromosome that is usually normal. Fragile X syndrome is the most common inherited form of male intellectual disability. Multifactorial disorders. Multifactorial disorders result from an interaction of genetic and environmental factors. The genetic tendency towards the disorder is modified by the environment. These interactions may either positively or negatively influence prenatal and postnatal development. For example, two embryos may have an equal genetic susceptibility for the development of a disorder such as spina bifida, open spine. However, the disorder will not occur unless an environment that favors its development, for example, deficient maternal intake of folic acid, also exists. Characteristics. Multifactorial birth defects are typically present and detectable at birth, and isolated defects rather than defects that occur with unrelated abnormalities. However, a multifactorial defect may cause a secondary defect. For example, infants with spina bifida often have hydrocephalus, abnormal collection of spinal fluid, within the brain as well. The hydrocephalus is not a separate defect, but one that occurs because the primary defect, abnormal development of the spine and spinal cord, disrupts spinal fluid circulation, allowing the fluid to accumulate within the brain's ventricular system. However, the infant who has defects other than those known to be associated with spina bifida probably does not have a multifactorial disorder. In this case, the spina bifida is more likely to be part of a syndrome such as chromosome defect, which may pose a different risk for recurrence in a future child. Multifactorial disorders are some of the most common birth defects encountered. Examples include the following: heart defects, neural tube defects such as anencephaly, absence of most of the brain and skull, spina bifida, and encephalocele, cleft lip and cleft palate, pyloric stenosis. Risk for occurrence. Unlike single gene traits, multifactorial disorders are not associated with a fixed risk for occurrence or recurrence in a family. Presence of a trait in a family, familial, means risks are an average rather than a constant percentage. Factors affecting the risk are as follows. 1. Number of affected close relatives. Risk increases as the number of affected close relatives, parent, full sibling, or child, increases. 2. Severity of the disorder in affected family members. For example, bilateral cleft lip is associated with a higher risk for recurrence in a close relative than is a unilateral cleft lip on one side of the upper lip. 3. Gender of the affected person. For example, pyloric stenosis occurs 5 times as often in males as in females. The couple who has a daughter with pyloric stenosis faces a higher risk for recurrence with future children because the genetic influence for development of the defect is greater if a female develops it. 4. Geographic location. The risk for some disorders, such as neural tube defects, is more prevalent in one population than another. Because a group at greater risk often lives near others with the same risk, occurrence of the disorder may be more frequent in that area. If multifactorial disorders had no environmental component, the risk for occurrence and recurrence would be a precise percentage rather than a range. However, if no genetic component exists, if the disorder were totally related to environment, the ability to predict the risk for occurrence or recurrence would be minimal. Environmental influences. Environment, for example, good nutrition that supplies all necessary raw materials for fetal growth and adequate folic acid intake before conception, may positively influence prenatal development. However, some environmental influences, such as teratogens, environmental agents, or mechanical forces that can cause defects as the baby develops, are harmful. Environmental influences on childbearing are those not known to have a genetic component. At one time, the placenta was thought to be a shield against harmful agents within a pregnant woman's body. Now it is recognized that most agents can cross the placenta and affect a developing fetus. Teratogens. Teratogens are agents in the fetal environment that either cause or increase the likelihood that a birth defect will occur. Some drugs have been definitely established as safe or harmful. With most agents, however, their potential for harming the fetus is not clear. Several factors make it difficult to establish the teratogenic potential of an agent. 1. Retrospective study. Investigators must rely on the mother's memory about substances she ingested or was exposed to during pregnancy. The conclusion that a specific agent is harmful and the ways in which it harms the fetus is possible only when many cases are collected in which the exposure history is similar and the birth defects are also similar. 2. Timing of exposure. Agents may be harmful at one stage of prenatal development, but not at another. Exposure may be harmful, but may vary with the prenatal development stage. 3. Different susceptibility of organ systems. Some agents affect only one fetal organ system, or they affect one system at one stage of development and another at a different stage of development. 4. Uncontrolled fetal exposure. Exposures cannot be controlled to eliminate extraneous agents or ensure a consistent dose. Interactions with other agents may reduce or compound the fetal effects. An agent toxic at one dose may have no apparent effect at another. 5. Placental transfer. Agents vary in their ability to cross the placenta. 6. Individual variations. Fetuses show varying susceptibility to harmful agents. 7. Non-transferability of animal studies. Results of animal studies cannot always be applied to humans. Agents that do not harm animal fetuses may damage the human embryo or fetus. 8. Risk for damage from an uncontrolled maternal disorder. Some maternal disorders, such as epilepsy or hypertension, may cause fetal damage if not controlled. A poorly controlled maternal disorder raises a question of whether the disorder itself or the medication used to control the disorder harms the fetus. Teratogens typically cause more than one defect, which distinguishes teratogenic defects from multifactorial disorders. However, children affected by single gene and chromosome defects are also likely to have multiple defects. Therefore, clinicians consider single gene disorders, chromosomal abnormalities, and effects of teratogenic agents when trying to diagnose an infant born with multiple anomalies. Hundreds of individual agents are either known or suspected teratogens. Box 4.3. Let's take a look at that. Box 4.3. Selected environmental substances known or thought to harm the fetus. Alcohol, aminoglycosides, anticonvulsant agents, anti-hyperlipidemic agents, statins, anti-neoplastic agents, antithyroid drugs, cocaine, diethylstilbestrol, DES. That apparently is a non-steroidal estrogen drug, which was previously used for pregnancy issues and some cancers, but is now very rarely used because of lots of bad side effects. Folic acid antagonists, infections such as cytomegalovirus, herpes simplex virus, human immunodeficiency virus, parvo, rubella, syphilis, toxoplasmosis, varicella, and Zika, lithium, mercury, retinoic acid, tetracycline, tobacco, and warfarin. Types of teratogens include the following: maternal infectious agents, e.g. viruses, bacteria, that cross the placenta. Drugs and other substances used by the woman, e.g. therapeutic agents, illicit drugs, tobacco, alcohol. Pollutants, chemicals, and other substances to which the mother is exposed in her daily life. Ionizing radiation, maternal hyperthermia, effects of maternal disorders such as diabetes mellitus and PKU. Theoretically, all or some of the risk in the developing fetus can be eliminated by avoiding exposure to the agent or changing the fetal environment in some way. Preventing fetal exposure. Ideally, prevention of exposure to harmful influences begins before conception because all major organ systems develop early in pregnancy, often before a woman realizes she is pregnant. To avoid some agents such as alcohol and illicit drugs, some pregnant women must be committed to making substantial lifestyle changes. The Office of Teratology Information Specialists is a source of information about drug use, includes therapeutic, illicit, and herbal, infections and vaccines, and maternal medical conditions, as well as exposure to common things such as caffeine, suntan beds, or fish. www.mother2baby.org. This website also has fact sheets nurses can provide to expectant mothers regarding various substance exposures that may be cause for concern. Infections. Rubella immunization, 28 days, 1 month, before conception, virtually eliminates the risk that the mother will contract this infection, which may damage the fetus severely. If a woman becomes pregnant within 28 days after immunization, fetal risk is considered unlikely. For infections that cannot be prevented by immunization, the nurse may counsel the woman to avoid situations in which acquiring the disease is more likely. Drugs and other substances. The U.S. Food and Drug Administration, FDA, established pregnancy categories for therapeutic drugs based on their potential to harm the fetus. The categories range from A through D and X. Class A drugs have no demonstrated fetal risk in well-controlled studies. At the opposite end, pregnancy category X drugs are well established as being harmful. Using this system, the provider should balance the woman's needs for the drug's therapeutic effects against the fetal need to avoid exposure to it. In December 2014, the FDA published the Pregnancy and Lactation Labeling Rule, which changed the content and format of labeling information for prescription drugs and biologic products. The new rule requires removal of the pregnancy categories A, B, C, D, and X from drug labels and replace it with information to assist the healthcare provider evaluate benefit and risk of the drug and counsel pregnant women and nursing mothers and assist them to make informed and educated decisions regarding the drug. The rule went into effect on June 30th, 2015, and is to be phased in. A woman's use of botanical preparations should be considered because some are harmful during pregnancy. Establishing whether an illicit drug can cause prenatal damage is difficult because women who use these substances often have other problems that complicate analysis of fetal effects. For example, these women may use multiple drugs and may have poor nutritional status, untreated sexually transmitted diseases, STDs, inadequate prenatal care, and stressful lives. In addition, illicit drugs are unlikely to be pure, and substances used to dilute them may themselves be harmful. Legal drugs may be combined with illegal drugs, and users may abuse legal drugs. Drugs are often metabolized and excreted in urine, including drugs in the fetal system. Fetal blood levels of drug often remain high because the fetus swallows amniotic fluid containing excreted drug products, even after the drug has been eliminated by the mother's body. The best action is for the woman to eliminate use of non-therapeutic drugs and substances such as alcohol. If she requires certain therapeutic drugs, the physician may be able to prescribe an alternative drug with a lower risk to the fetus, or may eliminate non-essential therapeutic drugs such as acne medications. Ionizing radiation. Non-urgent radiologic procedures may be done during the first 2 weeks after the menstrual period begins, before ovulation occurs. For urgent procedures during pregnancy, the lower abdomen should be shielded with a lead apron, if possible. The radiation dose is kept as low as possible to reduce fetal exposure. Ultrasonography and magnetic resonance imaging are the imaging techniques of choice for pregnant women. Maternal hyperthermia. An important teratogen is maternal hyperthermia. The mother's temperature may rise unavoidably during illness. Nurses should caution pregnant women to avoid deliberate exposure to heat sources such as saunas and hot tubs. Temperatures vary widely among public hot tubs, and a specific guideline for duration of exposure is difficult. The important factor is how high the woman's body temperature rises and for how long, not just the sauna or hot tub temperature. She should remain in a sauna or hot tub no more than 10 minutes and should keep her head and chest out of the water. Exposure to temperatures of 37.8 degrees Celsius, 100 degrees Fahrenheit, or higher is not advised. Manipulating the fetal environment. Appropriate medical therapy can help a woman prevent fetal damage that could result from her illness. For example, a woman who has diabetes should try to keep her blood glucose levels normal and stable before and during pregnancy for the best possible fetal outcomes. A woman with PKU should return to her special phenylalanine-free diet before conception to prevent high levels of phenylalanine in her body that will damage the fetus. Consuming folic acid before and during pregnancy can decrease the risk of neural tube defects in the fetus, CDC 2017. Neural tube defects occur early in gestation, before many women realize they are pregnant. Because nearly half of the pregnancies in the United States are unplanned, all women of childbearing age should consume at least 0.4 milligrams, or 400 micrograms, of folic acid daily. Women who have had a child with a neural tube defect may need a higher amount of folic acid, 4 milligrams, 4,000 micrograms, after consulting with their healthcare providers. The CDC, March of Dimes Birth Defects Foundation, and National Council on Folic Acid have initiated a national campaign to educate women about the importance of consuming adequate folic acid every day. The neural tube closes during the 4th week after conception, often before the woman knows she is pregnant. Nurses can help make women aware of their need for a supplement of folic acid before conception to help reduce this serious birth defect. Mechanical disruptions to fetal development. Mechanical forces that interfere with normal prenatal development include oligohydramnios and fibrous amniotic bands. Oligohydramnios, an abnormally small volume of amniotic fluid, reduces the cushion surrounding the fetus and may result in deformations such as clubfoot. Prolonged oligohydramnios can interfere with fetal lung development by interfering with normal branching and development of the alveoli. Oligohydramnios may not be the primary fetal problem, but related to other fetal anomalies. Oligohydramnios also may be a sign of reduced placental blood flow that may occur in certain complications of pregnancy. Fibrous amniotic bands may result from tears in the inner sac, amnion, of the fetal membranes and can result in fetal deformations or intrauterine limb amputation. Fibrous bands are usually sporadic and unlikely to recur. Because these bands can cause multiple defects, they may be confused with birth defects from other causes, such as chromosome and single gene abnormalities. Genetic counseling. Genetic counseling provides information and support to help people understand the genetic disorder they are concerned about and the risk for its occurrence in their family, and make informed decisions about testing and treatment. Availability. Genetic counseling is often available through facilities that provide maternal-fetal medicine services. State departments of mental health, intellectual disability, and rehabilitation services also may provide counseling services. Local chapters of the March of Dimes are an important source of information about birth defects and counseling services. Fact sheets and other information about birth defects and their prevention are available at the March of Dimes website, www.marchofdimes.com. Organizations that focus on specific birth defects provide valuable support and assistance in obtaining needed services for individuals and families affected by the disorder. Focus on the family. Genetic counseling focuses on the family, not merely on the affected individual. One family member may have a birth defect, but study of the entire family is often needed for accurate counseling. This may involve obtaining medical records and performing physical examinations and laboratory studies on numerous family members. Counseling is impaired if family members are unwilling to provide medical records and will not agree to examinations and laboratory studies. In addition, those who seek counseling may be unwilling to request cooperation from other family members or share newly acquired genetic information. Process of genetic counseling. Genetic counseling may be a slow process and is not always straightforward. Several visits spread over months may be needed. Multiple family members may be a part of the process. Tests for rare disorders may be performed at only one or a few laboratories in the world, and several weeks may be needed to complete them. Despite a comprehensive evaluation, a diagnosis may never be established. An accurate diagnosis is crucial to provide families with the best information about the risks for a specific birth defect, prognosis for the person affected, and options available to prevent or manage the disorder, Box 4.4. Even if the counseling does not provide clear information, expanding knowledge may allow a definitive diagnosis later, and families are encouraged to contact the center for updates. Individuals or families may request genetic counseling before or during pregnancy or after a child has been born with a defect. A genetic evaluation may include many factors, such as a complete medical history of the affected person, including prenatal and perinatal history, the medical history of other family members, laboratory imaging and other studies, physical assessment of a child with a birth defect and other family members as needed, examination of photographs, particularly for family members who are deceased or unavailable, construction of a genogram or pedigree to identify relationships among family members, and the relevant medical history. If a diagnosis is established, genetic counseling educates the family about the following: what is known about the cause of the disorder, the natural course of the disorder, the likelihood the disorder will occur or recur in other family members, current availability of prenatal diagnosis for the disorder, the ways a couple may be able to avoid having an affected child, availability of treatment and services for the person with the disorder. Genetic counseling is non-directive. The counselor does not tell the individual or parents what decision to make, but educates them about options for dealing with the disorder. However, families often subjectively interpret the counseling. Some parents may regard a 50% risk for occurrence or recurrence as low, whereas others may think a 1% risk is unacceptably high. In addition, the family's values and beliefs influence whether they seek counseling and what they do with the information provided. When risks and probabilities are discussed, these numbers should be stated in terms the individual or parents can understand, and their understanding should be verified. A 1 in 100 risk may sound higher to many people than a 1 in 5 risk. However, when the same numbers are framed in terms of percentages, the 1% risk is obviously much lower than the 20% risk. Supplemental services. Comprehensive genetic counseling includes services of professionals from many disciplines, such as biology, medicine, nursing, social work, and education. These professionals provide family support and referrals to parent support groups, grief counseling personnel, and intervention for problems that accompany the birth of a child with a birth defect, for example, socioeconomic and family dysfunction. Nursing care of families concerned about birth defects. Nurses have an important role in helping families concerned about birth defects. Some nurses work directly with family members who are undergoing genetic counseling. Many more nurses are generalists who bring their knowledge about birth defects and their prevention to those they encounter in everyday practice. Nurses as part of a genetic counseling team. Many genetic counseling teams include nurses. Genetic nursing may include the following: providing counseling after additional education in this area, guiding a woman or couple through prenatal diagnosis, supporting parents as they make decisions after receiving abnormal prenatal diagnostic results, helping the family deal with the emotional impact of a birth defect, assisting parents who have had a child with a birth defect to locate needed services and support, coordinating services of other professionals such as social workers, physical and occupational therapists, psychologists, and dietitians. Helping families find appropriate support groups to help them cope with the daily stresses associated with a child who has a birth defect. Nurses in general practice. Nurses who work in women's health care and those who work in antepartum, intrapartum, newborn, or pediatric settings often encounter families who are concerned about birth defects. These families may include a member with a birth defect. Other families may think they have an increased risk for having a child with a birth defect. Generalist nurses provide care and support that complements that given by nurses who work on a genetic counseling team. Women's health nurses. The nurse who provides care in women's health may encounter families who should be referred for genetic counseling. The ideal time to provide counseling is before conception, so the childbearing couple has more options if risks are identified. Personal and family histories are taken and updated during primary care visits, and the nurse may identify factors that could affect a future child before conception. For example, the nurse may identify a woman who belongs to a group in which the sickle cell gene is more frequent and subsequently arrange for testing to determine her carrier status. If testing reveals she is a carrier for the gene, the woman can be advised that she could conceive a child with sickle cell disease if her partner is also a carrier. If her partner has not been tested, the nurse can arrange for his testing. The carrier may want to advise blood relatives of the need for testing. Antipartum nurses. Antipartum nurses often identify those who may benefit from genetic counseling. The antipartum nurse also may assist families with decision-making, teaching about tests, management of abnormal results, and needed emotional support. Identifying families for referral. Nurses in antepartum settings often identify a woman or family for whom referral for genetic counseling is appropriate at the first prenatal visit, box 4.5. The personal and family history of the woman and her partner may disclose factors that increase their risks for having a child with a birth defect. In addition to the usual medical history about disorders such as hypertension and diabetes, the woman should be questioned about a family history of birth defects, diseases that seem to run in the family, intellectual disability, and developmental delay. Some people are reluctant to disclose that they have a family member with intellectual disability or a birth defect. The nurse can gently probe for sensitive information by asking questions about whether any family members have learning problems or are slow. The use of words that are lay-oriented and caring often elicits more information than clinical terms that may seem harsh, for example, low IQ. Helping the family decide about genetic counseling. If genetic counseling is appropriate, the physician or nurse midwife discusses it with the woman and refers the family to an appropriate center. However, the final decision rests with the person affected. The nurse can help the woman and her family weigh issues that are important to them as they decide. Genetic counseling can raise uncomfortable issues such as whether to undergo prenatal diagnosis, what to do if a condition cannot be prenatally diagnosed, and what options are acceptable if prenatal diagnosis shows abnormal results. Counseling may open family conflicts if information from other family members is needed, or if family values differ on issues such as abortion of an abnormal fetus. In addition, the test can show unexpected results. Box 4.6. Teaching about lifestyle. Nurses can teach a pregnant woman about harmful factors in her lifestyle that can be modified to reduce the risk for defects to offspring. The nurse can support the woman in making difficult lifestyle changes, such as stopping alcohol consumption, reducing or eliminating smoking, and improving the diet. Use of liberal praise can motivate a woman to continue her efforts to promote an optimal outcome. However, a negative attitude from nurses or other professionals may make the woman feel like a failure, and she may abandon her efforts to create a healthier lifestyle. Providing emotional support. Until they know prenatal test results are normal, possibly a period spanning several days or weeks, many women delay telling friends or family about their pregnancy or investing in it emotionally. When results are abnormal, women face more difficult decisions about whether to terminate or continue their pregnancy. Helping the family deal with abnormal results. Because prenatal diagnostic tests are performed to detect disorders involving serious physical and often mental defects, the woman whose test results are abnormal must confront painful decisions. For many of these disorders, no effective prenatal or postnatal treatment exists. Only two choices may be available: continuing or terminating the pregnancy. In addition, the decision to terminate a pregnancy must be made in a short time. Making no decision is effectively a decision to continue the pregnancy. Although the physician or genetic counselor discusses abnormal results and available options, the nurse reinforces the information given to these anxious families and supports them. When test results are abnormal, nurses should expect the couple to grieve. Even if a pregnancy was unplanned, the woman who undergoes prenatal diagnosis has already made the initial decision to continue the pregnancy. If results are abnormal, she must decide again if she will continue or end the pregnancy. Both parents will experience similar feelings of grief and loss when an abnormal diagnosis is detected prenatally. Intrapartum and neonatal nurses. Nurses working in intrapartum and neonatal settings encounter families who have given birth to an infant with a birth defect that may have been unexpected. Stillborn infants sometimes have birth defects that contributed to their intrauterine death. In addition to the loss of their baby, these parents face pain because of the associated abnormality. An autopsy may be performed to document all anomalies and establish the most accurate diagnosis of the birth defect for future counseling. Nursing care for families who experience a perinatal loss, whether a result of the infant's death or the loss of the expected normal infant, is addressed in Chapter 11. Nurses who care for these families in the intrapartum and neonatal settings will find the parents anxious, depressed, and sometimes hostile because of the unexpected event. The family's usual coping mechanisms may be inadequate for the situation, or new coping mechanisms may not have been developed. Diagnostic studies are often recommended soon after the birth of an infant with an abnormality to establish a diagnosis and give parents accurate information about the abnormality and the options available to them. However, a high anxiety level reduces their ability to understand the often massive amount of information received. The nurse is in a position to evaluate the family's perception of the problem, help them understand the diagnostic tests, reinforce correct information, and correct misunderstandings. In addition, the nurse is often most therapeutic by simply being an available, active listener, helping ease the family's pain over the event. Nurses should encourage families to contact lay support groups, which are significant sources of support because members fully understand the daily problems encountered in the care of a child with a birth defect. Such groups can help the parents manage the stress and chronic grief associated with prolonged care of these children. Support groups also can help the parents see the positive aspects and victories when caring for their child with special needs. Internet sites regarding specific birth defects are often available to offer parent education and support. Pediatric nurses. Children with birth defects typically have numerous recurrent medical problems. They usually are hospitalized more often and for longer periods than children without birth defects. Travel to specialized hospitals may be needed for their care, adding to the family's stress. These families often incur substantial expenses for medical care and equipment not covered by insurance or public assistance programs. Transportation costs to reach distant healthcare facilities may be difficult to pay. Household income may be lost because one parent stops working to care for the child. Family dysfunction is common, and the strain of caring for a child with a serious birth defect may lead to divorce. Siblings often feel left out of the parent's attention because the needs of this child demand so much of the parent's time. The nurse case manager can reduce the family's stress by helping them locate appropriate support services. The nurse can contact social services departments to help the family find financial and other resources needed to care for the child. If parents have not connected with a lay support group, a nurse can encourage them to do so.